All right. Now, if that guy that's the tights comes anywhere near me, there'll be blood. Okay. Welcome, everyone. Congratulations, Ollie and Richard. This is a great innovation, a great concept, and I think will change the way we do things in the future. I know it's caused a few ripples amongst the grey hairs and no hairs, but because it's all cool and modern. But I think this is the way to go for the future, and I think the days of us travelling across the sky in cigar tubes to conferences, apart from getting pissed and having a good time, is actually on the way out. So I'm afraid there's going to be some science here, some statistics and a few things, but essentially this is a story which has been part of my life for the last 20 years. I did some research on this a few years ago, and I think it, in many ways, is now finally coming to fruition that what we are using these things for really is to support the patient or the host to try and fly away from the stress that he or she has been exposed to because the fight is too much. So I guess we can talk about evangelism and creationism, but I think at the end of the day, we still are physicians where there's an art, but we need the science to support that. And science is an interesting thing. It's the beauty of the world. Richard Dawkins talks about science as being the religion of the world. But I think we have to make sure that science is not something cast in stone. It's evolutionary, but we must always go back and learn from our forefathers. Now, for those of you who have interest in the time, this is the Nobel Prize website. And no less than 5 Nobel Prizes have been awarded to the description of catecholamine and the sympathetic nervous system. These are great papers. Take the time one day to go onto the website and read all the papers written by these great scientists. And all of a sudden, things written in the 1950s become as germane today as they were then. Despite the fact that we're all cool and web connected and locked in, a lot of those concepts came from very smart people back in the old days. And we forget those things, thinking that the new world starts a new era. So I'm a great believer in history, a great fan of history, and I've been thinking about this topic for a long time, based on a lot of the pioneering work of our forefathers. Too many men there, not enough girls. Now, when we're talking about the system, we're talking about neurohormonal vasoregulation. This is not a complex, plug it in, get it out, instant gratification type system. It's a highly complex neurohormonal system. And again, this is all physiology 101. You all know this stuff. The catecholamines, where we go. The catecholamines are endogenous, and noradrenaline, not norepinephrine. This is an American slide. We don't have an epinephrine gland. We have an adrenal gland. Noradrenaline is released from the presynaptic membrane and is the predominant neurohormonal endocrine hormone that acts across all receptors on all tissues. And in fact, if people believe this, we would have avoided the mess that occurred in the next 20 years about making synthetic drugs. And noradrenaline is actually the drug that actually confines and controls human responses. And it's released preferentially by adrenaline from the adrenal gland, which activates it by presynaptic release. And also adrenaline has its own specific effects. And the effects that adrenaline actually produces are in fact physiological and not pathological. Now, of course, these hormones release induce a whole array of chemical changes that have evolved over millennia. This is the essence of the fight and flight response. That the host can stand back and fight the man in the suit or fly away to somewhere safe. And this is where most of the Nobel Prizes have actually been awarded, in defining the modeling of how these things work. And it's a beautiful structure, it really is. It's incredibly complicated and fluidic, and there's marked inter-individual and intra-individual variation in health and disease. And this is what we're doing in our patients. What we're doing is trying to augment the system when it becomes overwhelmed or swamped by the insult, rendering the host unable to fight or fly away. Of course, it's more than just the catecholamines. There's a whole range of chemicals that act in concert with these things. Vasopressin from the posterior pituitary and cortisol. And sort of makes sense, therefore, that having some kind of combined pharmacological cocktail may actually improve this. So this is really where it's come down to in terms of what we're doing. And this is a far cry from the thought about sticking in a a vasopressor, which can constrict the arteries to push the pressure up. That's a nonsense. And I think that's something which we've actually got to move away from. On that point, this is where most clinicians get stuck, because most clinicians are stuck before Guyton really defined the system. We are obsessed with this thing, blood pressure. We have all kinds of funny toys about cardiac output, and we think about squeezing the arteries for that pressor to push up the pressure. But in fact, this is only the afferent or conductant system. It actually doesn't mean anything in terms of organ perfusion and utilization. And what Guyton described back in the 1950s, and he's a very, very smart guy, and go and read his papers, they're beautiful papers, was in fact that this is a circuit. Oops. The heart doesn't push blood around the body. It's a nonsense. There are two circuits going in parallel. The flow this way has to equal the flow that way. But the pressure difference is extraordinarily different. A mean pressure here of 60 or 70, a mean pressure here of about 10. So therefore, this system is probably the most important determinant of that system when this pump is working okay. And in fact, what we talk about nowadays is finally emerging is the main effect of catecholamines on vasopressiveness is here, on the venous side of the circulation, to produce a stressed volume, to venoconstrict, to augment venous return, to promote forward return. And finally, this concept, which has bedeviled students for many years, because it's hard to measure, it's hard to understand, is now coming to the fore. In fact, most of the vasopressors that we talk about, adrenaline and noradrenaline, apart from pushing the pump a bit faster, most of its effect on improving vasoresponsiveness is actually increasing the stress volume. If you look at animals in the wild, the cheetah that can go from 0 to 70 in a second has a spleen that can contract immediately and injects about a litre or so of blood to increase venous return. And that's because it's a fight and flight animal. Our ability to increase our stress volume is about 15%. So when we get patients in, and this is important shortly about the FEAST study, what we're doing here is actually improving venous return. And the whole focus on arteriolar, TPR, SVR, cardiac output really is overstated. I've been saying this for 20 years, and it's finally becoming into the mindset of people. So adrenaline, noradrenaline certainly act by increasing this thing, but the afferent conductance, but also by maintaining adequate venous return. And this is where hypervolemia is sort of important. Okay, going back into how this lack of translation occurred. Well, Barcroft in 1949 described these studies. These are 7 medical students who volunteered, of course, and he infused noradrenaline at high dose into these students, again voluntarily, and then did a crossover with adrenaline. And he measured their blood pressures and their heart rates. And he showed it very nicely, in fact, that there was a pressor response and a reduction in heart rate that you saw with this, and the reverse with adrenaline. And this became the basis by which catecholamines in humans was thought about. And this is actually his goal, but a few years later, defining the differences. And most of you, if I asked you to write a table about the effects of catecholamines, will come up with this sort of crap, okay? Where you have alpha and beta and different systems and smooth muscle and heart rate, and it's all bullshit. Because I mean, you don't know. You can't predict the effect in humans who are at rest, or a person who's got cardiac disease who's now got septic shock. What you're seeing, in fact, is a range of expressions. And the ability of the patient to mount a response depends upon their own intrinsic system, but also their extrinsic response to infusions. So what I want you to think about in this process is that when we give a patient a catecholamine, what you're doing is replacing a failing endogenous system with an exogenous infusion and looking for a response for that. And don't forget about low dose, high dose, that sort of stuff. You may need to have a huge dose to get a response in a patient, provided there is a response, but the equivalent may not occur at low doses. Right. So that's a bit of background physiology, which I find fascinating, and I think there's nothing new there. It's all old. But I think we now go into the realm of the world's biggest lie, evidence-based medicine. Okay. Unfortunately, in terms of this sort of area, it's been dominated for many, many years by basically n equals 1, n equals 10, n equals 3. The old story, there's good evidence, n equals 1. In case to case, n equals 2. In case to case, in my experience, n equals 3. But I think one thing, to be a little bit provocative, is that this stuff, these drugs, have hijacked critical thinking in cardiovascular physiology and pharmacology for 25 years. This stuff is basically the angel of the devil. And in many ways has hijacked critical thinking about how we do this. All the science, all the Nobel Prizes and all the Barcroft and Guyton stuff was hijacked by this stuff. And I believe we're finally seeing, hopefully, the end of this crap. If you look at the endogenous or the natural occurring agents, okay, they catecholamines. That's what they are, okay? These synthetic drugs are basically analogues of the two compounds, and all you're doing with these, by adding on these synthetic things, is extending the amine link. And looking at structure-function relationships, the length of this chain really determines the affinity for beta receptors. So all you're doing is actually getting a very large, clumsy beta agonist, which, as we know, is really the receptor population that governs regulation at rest. Alpha systems are the ones that determine the fight and flight response. So what you're doing is generating a major beta effect. More importantly, of course, is at the cost. A ampule of adrenaline, God's own inotrope, costs about $1. But this cool stuff is really expensive. And therefore, there's a real motivation by the companies to get this stuff into your practice to generate a return on their shareholders' investments. And that's what's driven catecholamine physiology and thinking for many years. I'm being slightly iconoclastic and provocative, but it's true. Where did you last get a notepad like this? Adrenaline. God's own inotrope. We market anything, okay? And I'll tell you, this is actually not a benign thing. When I talk about fluids later on, this is even a bigger issue in the fluids story. So going at the turn of last century, okay, for many years, dobutamine got a big push by Lilly and the companies to become the pressor of choice for the failing patient. One of the major advantages and marketed was that it could be given by a peripheral line. And that was a big push for these guys. And of course, that's what did it. And we saw a whole array of these sort of studies, focusing on oxygen delivery, VO2, looking at shitty endpoints, and small studies, and weird dose ranges, and all these things for class 4 evidence. But this became the main driver of septic shock resuscitation back in the end of last century. And in fact, dobutamine was the protein C of last century. Okay. Finally, along came Darren Halen from Canada, and he did one of the first systematic reviews when he pulled all the studies, fueled mainly by Michelle Hayes' study in 1994, and really said this whole supernormal activity really was baseless in terms of physiology. And in fact, if anything, all it did was give you an index of patients who could respond to a catecholamine as an index of reserve. Mirabile dictu. I mean, what you're seeing, if patients can respond to it, they'll do better. This is basically a glorified stress test. And you don't need to have a drug that costs $1,000 to do this. Furthermore, as we go into the next century, we saw the use of catecholamines, the ones that we talked about earlier on, in septic shock. Again, 200 patients in 10 to 20 studies. This is the totality of evidence. All shitty endpoints, all grade 3 and grade 4. None of these endpoints are, the reason why they're shitty is because none of them are patient-centered. It's all about numbers and about surrogates. It's not about what happens to the human being. And therefore, anything with a surrogate becomes more or less meaningless. So again, a lot of confusion here, but still this drive to use combinations of dobutamine and dipexamine and these things in combination against these weird sort of physiological endpoints. And then, of course, along came Rivers. And again, in many ways, this is also hijacked critical thinking. Now, Manny Rivers is a really good guy. I've met him, and he's a class act. What he did in Detroit was exactly what Scott did, was talking about. He took a really dysfunctional emergency department where his patients were doing very badly, different demographics, different socioeconomic backgrounds, and he himself, in the ED, treated patients properly with an algorithm that he envisaged and developed an early goal-directed therapy approach, okay, using this sort of combination of stuff. Okay. Not surprisingly, his patients did better than the control group. This is more about Manny Rivers and his team in Detroit rather than the algorithm. And yet you'll hear this later on, in terms of we're now doing a trial to try and evaluate this. But whilst I really thought what many derivatives did was great, what concerned me, of course, was that he brought back in inotropes, dobutamine, as the pressor of choice in patients with septic shock. That really distressed me because I thought we're finally getting away from all this stuff and starting to use catecholamines, noradrenaline and adrenaline, as first-line drugs, as exogenous hormones to replace failing systems. We'll see with the results of future trials. So, as we go into this era of high-quality trials, why were the human trials so bad? Well, basically, none of these trials up until this point in around 2000 had any evidence. This is on a platform of enormous basic science research. Most of them were underpowered, observational and descriptive, variable dose ranges, variable endpoints, nothing on mortality or patient-centered outcomes. This whole oxygen delivery focus, and of course, a huge commercial influence. And most importantly, those people who were doing these sponsored trials resulted in enormous publication bias. So much so that, in fact, what happened in Europe and the United States became the actual basis for guidelines that were then rolled out across the world. And I had a real problem with that. I'll mention it shortly. And basically, I believed, when this was happening, I was doing my PhD in catecholamines, that many of these principles were basically misapplications of the basic principles that we saw from our founding fathers many years ago. So, we go into the whole era now of guidelines. And this is the first and second iteration of the surviving sepsis guidelines. And basically what they did was in good intention, but heavily compromised by industry support and eminence-based medicine, where he who spoke loudest got his way, resulted in a whole series of guidelines which were produced. And basically they did, which really gave me the squirts, was divided it into inotropes and vasopressors. And the inotropic recommendations was primarily still to use dobutamine based on Mani's trial, which we, despite the fact that dobutamine was slowly becoming recognized as a weak beta agonist. So the recommendation really comes around the Rivers trial. And I don't think this really has any sort of role in patients with septic shock, or dare I say, shock at all. But then they go into the pressor group, which is those things that squeeze the arteries. I've just told you that it isn't where they work, okay? And they put up a couple of recommendations. And this really gave me the shits, okay? Noradrenaline and dopamine were the drugs of choice, the pressors of choice. And this is based entirely on North American and European practice. And adrenaline, epinephrine, was really an alternative, but really to be used with great caution because it was toxic. And really shouldn't be given as an initial drug. Well, that's fine if you're working in New York or Seattle or Sydney or in Paris or in Belgium. But it's a problem. Oh, sorry, I'll go back 1 second. I hit myself here. Anyway, the problem that the adrenaline got was, again, a misunderstanding of what it did. There was a great concern that adrenaline caused dead gut. And dead gut was attributed to a few studies where they infused adrenaline and measured pH, or PHI, which is basically a tonometric method of measurement of gastric pH. And sure enough, noradrenaline and dobutamine didn't increase pH, but adrenaline caused a reduction in PHI. But look here, it normalizes in a short period of time. Equally, there was an increase in lactate generated. This is a very nice study from patients with malaria. Dopamine, no change in lactate, adrenaline does. Yes, we know this. Adrenaline causes a hyperlactatemia, and it causes a reduction in pH as a consequence. But lactate is good for you. It's a brain fuel. It is what adrenaline does under periods of stress. So therefore, it's a normal response to a sick patient. Now, I understand that people get toey about falling pHs, but again, this isn't toxic, and this is the basis by which adrenaline got a very bad rap. And my concern really was beyond the ivory towers. This is Johannesburg. This is Baragwanath Hospital, one of the biggest hospitals in the world. The ICU I went in there had 15 beds for 5 million people. The only inotrope available in this country is adrenaline. They can't afford noradrenaline, let alone leave a miracle. And these guidelines, therefore, had a big impact on whether or not they were now practicing at variance to the great white doctors in the North, because the drug of choice I'd used for many, many years was actually now regarded as an inferior drug. And the same thing happened in Eastern Europe, in Uzbekistan and Mongolia and those places. People couldn't afford to give it noradrenaline, let alone adrenaline. And so I thought, and we wrote a letter to the editor about this, that the generalizability of these guidelines that are developed in high-income countries, fueled by industry, need to think beyond their square and have an impact on places that are low and middle income, because this might not necessarily be good medicine, or even what they're doing was bad. And so that really became the impetus to do some high-quality trials to answer the question. We had all this noise with the synthetic drugs. We had guidelines produced which were influenced by commercial influences and regional differences, but no one had done a trial comparing adrenaline and noradrenaline, because it was something which we needed to do, for goodness sake. It's been around for 100 years. So the way to get this answered is to go to, of course, the font of knowledge, the Cochrane collaboration, which always gives you an inconclusive result. But again, meta-analysis is like metaphysics. It doesn't give any real answer. It makes you feel good. But the first Cochrane review of catecholamines was done in 2007. And this is the totality of higher quality trials comparing adrenaline versus noradrenaline, 0, noradrenaline plus dobutamine versus adrenaline, and noradrenaline versus dopamine. 111 patients. This is the entirety of published evidence for catecholamines, something we do every single day of our lives, for which everyone has a very strong opinion about what it's all about. And this is the reason why we decided to do some trials. And we finally have now, for the first time, some emerging trials. This trial we did in Australia, to get this funded was nearly impossible. When I had the reviews for this, they said, "Why are you bothering? We all know adrenaline is bad. Don't give it." And I wanted to do a phase 2 trial, looking at really comparing adrenaline versus noradrenaline in ICU patients. There wasn't enough information to do this, to do a trial, or money to do a trial looking at mortality. And we chose a pragmatic design, what the clinician felt at the time of the day what the target mean arterial pressure should be for that patient. We didn't prescribe a number, because it varies. And once the patient got that prescribed target mean arterial pressure, we didn't mandate cardiac output or urine output or lactate or cardiac index, all those things. That was the endpoint. And we looked at the effect on mortality. And we showed, not surprisingly, no difference in death, but in fact the time to achieve the target MAP goal, in fact, was lower with adrenaline than it was with noradrenaline. Not different, but there was a lower time rate. And I guess this is quite important information, the first time that a trial like this had been done. And again, the same thing with septic shock. Importantly, of course, lactate went up in patients who got adrenaline, as you would see very nicely. In the first sort of 24 hours, that normalizes. It also causes an increase in heart rate and an increase in blood sugars. Again, normal responses. This is what adrenaline does. But again, interpret this data in the context where there's no difference in organ failures, no difference in death, and therefore these effects, within the context of a blinded, randomized control trial, suggest that these effects are not necessarily harmful and may actually be beneficial, given that the primary outcome for this trial was duration of shock. I think this is new information which really has begun to crystallize some of the earlier work done by the basic scientists. At the same time, the French did a trial, Delardier, similar to ours. They were naughty. They changed their primary outcome halfway through the trial, from shock resolution to death. And that was why this got published in The Lancet and ours didn't. And you can quote me on that, it's true. Okay, their trial was 300 patients, primary outcome measure, comparing noradrenaline plus dobutamine, the European cocktail du jour, versus adrenaline. Okay, again, a very complex algorithm reflective of practice in Europe. They mandated a target MAP of 70. Why? Thumbs up, don't know, it's a good number. Okay, rather than a clinician one. But again, that's reflections of practice at the time. And again, they showed no difference in death between adrenaline and NORAD plus dobutamine as a cocktail. Again, suggesting now that adrenaline, in fact, wasn't the drug of toxicity that the guidelines said it was. Of interest here, the long-term outcomes, okay, and 3 months don't separate. A separation here may be favoring adrenaline. But again, importantly, their study also confirmed that adrenaline caused a hyperlactatemia and no differences in mortality. So the take-home messages from these trials, comparing adrenaline versus other drugs, is that, sure, you can get a high lactate, you may get a fall in pH. If that worries you as a clinician, then by all means change. But don't necessarily get told about it because it's not bad for the patient, and in fact, may even be good for the patient. The Europeans did another trial, which I think is really the gold standard. This guy, Daniel de Back, is a very good guy. He's a very smart guy, and he's, I think, a rising star in this area. And the Europeans did a big study looking at practice, an observational study, and their observational study suggested that dopamine actually had a higher increase in complication rates compared to noradrenaline in Europe. And so they did a large-scale randomized controlled trial published in the New England Journal of Medicine last year. And this is really, I believe, as close as you'll get to a definitive answer. And this study was informed by our CAT study and the French study. Basically, 1,500 patients, primary outcome at 28 days, a rather big reduction in mortality. And they showed no difference at all between noradrenaline and dopamine on overall survival at day 28. Again, affirming the fact that, in fact, adrenaline and noradrenaline, the catecholamines of choice, in fact, were beneficial. In fact, the North Americans for many years had a moratorium on using noradrenaline. Lever-fed is what they call the stuff. Lever-fed makes them dead. And that's finally turning around. Of importance here, of course, is that if you look at this trial further, dopamine was associated with a high increase in the incidence of bad arrhythmias. And this is new information compared to noradrenaline, when noradrenaline was thought to be pro-arrhythmic. And this, I think, really is a key message of this large trial. They pre-specified some subgroups, patients who had hypovolemic, cardiogenic, and septic shock. And what do they find of interest in this group? The patients who did best on noradrenaline, NORAD, lever-fed, vasoconstrictor, were patients with cardiogenic shock. And this is the first time we've got evidence which suggests that noradrenaline is an effective agent in patients with cardiogenic shock. Now, this is not news to me or news to us in Australia, but this is huge news in places outside Australia whereby cardiogenic shock was the exclusive domain of dobutamine. And I think this is important information. Very briefly, vasopressin. As I mentioned earlier on, vasopressin is an adjuvant hormone, and we started using it primarily to spare or reduce doses of catecholamines, a catecholamine-sparing agent. And it seemed to work. But these our Canadian friends, Jim Russell in Vancouver, did a very nice study, the VAST study, published in the New England Journal. Large-scale trial, basically comparing vasopressin versus in low doses versus noradrenaline without vasopressin in septic shock. And again, showed there was no difference at day 28 mortality between vasopressin and noradrenaline. Of interest, of course, what he did show in a subgroup was that patients who had less severe septic shock seemed to do better with vasopressin than those who had more severe septic shock. And so how does that help us? We generally give vasopressin in patients who we want to try and save because they're sicker. But in fact, it seems to only work in patients with a less severe septic shock. And I think what this means to us really is that there is a description here of host response. If patients can respond to vasopressin and to noradrenaline, they're less sick. And once you get to the exhausted responses, then it doesn't seem to work anymore. That's a pity because I thought that the vasopressin story was a cool one. But as a consequence of this trial, I stopped using it. Again, steroids, big topic. I won't go into it in detail, but it appears that the same concerns about steroids being catecholamine sparing is also somewhat uncertain and probably isn't that effective. And we're doing a large-scale trial to answer this question. The updated review after the publication of all these trials that have occurred in the last 10 years have showed some interesting observations. An additional 17 studies, now 3,000 patients. Most of the trials are comparing adrenaline and noradrenaline, and adrenaline and dobutamine. And basically, what this systematic review came out and said really was there was no difference between any of the vasopressors, adrenaline, noradrenaline, and that the selection is based on preference. But they did make a comment that dopamine as an agent, probably of the catecholamines, was the least effective. It caused more arrhythmias and less efficaciousness. And of course, the synthetics, there's a problem with those too. So, recently, the guidelines have been amended, and I was asked to comment on these following our papers, and these were my thoughts. And I thought that really what they should say is the following: that noradrenaline is probably the vasoactive drug of choice, and that's not a pressor or an inotrope. It's a vasoactive drug of choice in all patients. Adrenaline is eco-effective. It has transient metabolic effects, which are probably benign, but there's a caveat that if you're worried. Dopamine causes adverse effects, particularly arrhythmia, and why would you give it, given the expense? Dobutamine is the instrument of the devil, don't give it. Vasopressin may have catecholamine-sparing effects, but really no clinical benefit in septic shock, unfortunately. And steroids, we don't know. What about these things? These are really, really, really expensive drugs and really cool. Okay? And I've seen these creep now into our practice. There's a good basis for these drugs. They were marketed very badly by the companies. What these drugs do primarily is something which the catecholamines don't do. They don't act via the alpha and beta receptors. The most important function is in lusitropy. It causes ventricular relaxation. So it improves venous return. Okay? In patients who've got stiff ventricles. Outside that, they probably don't have any benefit. So their main role is really in patients with shock due to poor ventricular diastolic function. And that's hard to measure. And I see this stuff coming into practice more and more now in septic shock and in all comers. Of course, the cardiac surgeons love this stuff. It's got bad kinetics because you can't infuse it and it accumulates and it works in renal failure. And most patients in ICU who go onto stuff have to be rescued with noradrenaline. Well, then why give it in the first place? Beyond me. Okay? And the only trial which can support its use is quite a nice study. Alex Mabaza, another classy guy from the US, published this trial. This is in patients with acutely decompensated cardiac failure, not ICU patients. He compared toxin A versus toxin B. Okay? And it showed no difference in outcome. Rabla dictu. However, what he did see was that levosimendan actually did what it was supposed to do and changed BMP, which is a marker of diastolic relaxation. Okay, so if you've got a patient who you're really struggling with, who's got a stiff ventricle, and they're not on huge doses of catecholamines, and they may help you, and you've got shares in the company, give it. But apart from that, I wouldn't give it. So, to conclude, my friends, here we are. We finally have a body of high-quality trials on patient-centered outcomes in the critical population. It's finally emerging. It's taken us 100 years to get there after our forefathers in the early days. Go back and read those Nobel Prize papers. There really is no evidence of superiority of any currently used catecholamine, solely or in combination, over noradrenaline or adrenaline, on shock resolution or in organ failure or mortality. Unfortunately, the catecholamine sparing strategies, vasopressin and steroids, have an undefined and unproven role. And really, if it isn't proven and may cause harm, don't give it. And this is the key message. The role of catecholamines of our patients is evolving from a rescue therapy. Don't go there and rescue them with catechols. Start giving it with the oxygen. Fluid load with adrenaline. Okay? To neurohormonal augmentation therapy, vulnerable patients. And of course, it isn't open-ended scale. If patients are requiring massive doses of noradrenaline, look for other causes, obstructive causes, hypovolemia, dyspnea, thorax, and all those things. But if you get into that crazy level, then what you're doing really is defining the patient's host response to fight that insult. And there you've got to think about how much you're going to go on for. And I believe it's biologically implausible that any synthetic drug will produce improvements in patient-centered outcomes at this point in time. And really, we're finally seeing the application of some of the science and some of the patient-centered trials, which need to be incorporated into bundles of care and guidelines outside the imperative of industry. And with that, I thank you for listening.